understand that some of you are having a hard time logging on. I did this morning. I tried to use the site for a meeting this morning, and I had some issues, but then it seemed to correct itself. But now Jake tells me that it's been an issue for him and a couple of other people. So I apologize. I will talk to GoToMeeting after the session is done and try and figure out why we're having problems. There are a couple of people on the telephone. Would you like to identify yourselves?
Hey, Rick, it's Dennis Correa.
Okay, Dennis is on number 1, Jake, and somebody else on the telephone?
Yeah, this is Peter. I drove my phone from my car because we had a big storm and the power's out on the island. So
Oh.
sitting in my car.
Okay. All right. How long does that usually last, Peter?
I don't know. It came about 2 in the morning. Came about 2 in the morning. The airport's out all over the island, and it's out of power. I hope it's not as bad as Puerto Rico.
I hope so too. Well, I mean, you've already been without power for half a day, pretty much, haven't you?
Yeah. Yep.
All right. So let's make a note of who we've got here. We've got Jake, Dennis, Peter. There we go. Jamie, Jay Crookman, Joe Blanchette, Paul Frieda, Thibault. All right. Excellent.
And Christine Sibley.
And Christine Sibley. Okay. All right. So I'll just call out everybody that I've got, and then, hey, Thibault. I just call out everybody that I've got, and then we'll start. So, Jake, Dennis Correa, Peter Kafka, Jamie, Jay Krukman, Joe Blanchette, Paul Frieda, Thibault Lincecum, Christine Sibley. Did I miss anybody? Okay. Now, next. Jamie, have you been with us before?
No.
Okay, well, welcome.
Well, thank you.
You are very, very welcome. Normally what we do is we'll spend time with you first because you haven't been with us before, but I want to check in with Thibault because I don't know if he'll last the whole meeting, and he had some surgery and we just want to check how he is. How are you?
Oh, pretty good considering. I just got out 2 hours ago.
Oh, really?
And some pills and had some food and lay down, and it was time for the meeting.
All right. I mean, you sent me a quick note that the surgery went quite well, no complications. Can you tell if you're in less pain or not?
Yeah, it never was serious. As soon as I woke up after the surgery, it was, tolerable.
Right.
If I moved. And it actually got a little bit worse while I was there at times, mostly due to headaches. But they went away, and I don't have one now. So the biggest, problem with after any surgery, the constipation. But I got through that. When I first got there, the nurse that was wheeling me away from the waiting area asked what kind of music I liked, and I said classical. So she put on Tchaikovsky's Dance of the Flowers, and it was pretty loud too. And as we rolled down the hallway, people would stop what they were doing and start dancing in front of us and twirling around and going along with the procession. Mm-hmm. It was like a musical or a dream sequence from a TV show, and they hadn't even drugged me yet.
Are you sure?
Really? And then they drugged me, and then I was out real fast. Fentanyl.
Okay. What did they find? Anything unusual in the surgery, or was it all?
Well, they said they were going to definitely remove the backs of 3 vertebrae, and they did. And they say they might have to remove more if that's not enough, but fortunately that was enough. And he didn't say he was going to remove any of the tumor, but he saw some of it was accessible, and he could see how it was affecting that nerve to my right underarm that was tingling. Mm-hmm. So he did clear off some of the tumor away from that nerve. And because of, the nerve being handled, that area is numb now.
Right.
Hopefully I'll regain my feeling, and it did eliminate the tingling problem.
Will you be able to send tissue away for analysis?
Yeah, I asked Dr. Antonarakis about doing that, and he said they keep that stuff routinely, so they can definitely use it for testing later if needed.
Okay. Well, I mean, if it were me, I would be looking to get that sequenced as soon as possible. You never know what it's going to show you. And, it just could turn up a nice surprise, and that would be great.
Yeah, I've got a meeting with him in a week, and we'll talk about it.
I know that if they do it in-house, it's going to take them quite a bit longer than if they do it out-house.
Mm-hmm. Well, I've got to get radiation, and there'll probably be a delay in between radiation and being able to start any clinical trial anyway.
Okay, excellent. And it looks like you're on steroids?
No, just a little bit. 10 milligrams of prednisone a day, which is what I was already taking because they always prescribe that along as a Zytiga.
Mm-hmm. All right. Anybody want to chat with Thibaut?
Oh, I'm just glad to hear that you're doing okay, Thibaut. This is Jake.
The biggest challenge now is trying to teach my 4-year-olds not to come crashing into me.
Oh boy, yeah.
Beating on them. They want me to save them. I'm like, don't touch me.
Please, Daddy needs a break.
Yeah.
Oh wow.
Daddy can't pick you up. Daddy can't fight with you. Daddy can only walk slowly and sit down. That's it.
Okay.
Well, best of luck to you.
How long do you think Daddy will be in this situation before he's back to normal? So they give Daddy an indication?
Probably a week.
Okay, good. Excellent.
I'm going to see my primary care doctor on Friday and ask for his blessing for returning to driving.
Oh, good. Okay.
Weird thing that happened that I don't have an explanation for is in all my blood tests ever, right up to and including the pre-op exam, my red blood cell count was normal, like just under 5K.
Right.
And the first test and every test at Johns Hopkins said it was 3K, which is way below normal. And nobody made a big deal about it. But I don't understand why it would have changed so much. It's like there's a difference in the labs, but that's a pretty huge difference.
Yeah.
So I'm going to talk about that with Dr. Berard as well.
So now, So they are showing, right now they're showing a lower red blood count than you normally see. Is that right?
Yeah, it's normal. It's like 40% lower than it was before.
Okay.
And it was only like 1 week between tests.
Well, you know, it would be good if you could get tested again by your regular lab right now.
Yeah, I think that's probably the best first step. And if it says I'm normal, then we can just, I guess the labs are different somehow.
Yeah. Absolutely. Okay. Anyone else chat with Tebow before we either move on or we lose Tebow?
And I might fall asleep, so.
I know. That's why I wanted to get to you first. Make sure
Thanks.
that we got you whilst you were still with us.
Probably
As long as you don't start snoring while you're online.
I'm putting myself on mute right now.
Okay.
Okay. Okay.
We have a new caller, Rick, on the phone.
Okay. Who's joined us by phone?
I just dialed. I don't know if you're talking about me. This is Sylvester.
Hello,
Yeah,
Sylvester.
we figured it was you, always late to the party.
Yes, I am. Hello, everybody.
Hello, Sylvester. Well,
Good to see you again.
I'm here.
Okay, so let's go back to Jamie since she's never been with us before. Jamie, what we usually ask new folks to do is to talk a little bit about their situation or the situation of the person they're caring for, just to give us some idea of what the issues are. And then if you have any questions, you can pose them to us. We'll pose questions possibly back to you or make any suggestions that we have. And we go from there. So if you're comfortable, why don't you tell us I guess my first question is, how did you find us and what brought you to the call?
Okay, can you hear me?
We can hear you.
Okay, I'm not really comfortable doing this. I'm here with my sister Christine Sibley because Dave Sibley's my dad.
Right.
So Chris is our advocate, and she really wanted me to listen in to kind of get an idea of what other people are going through.
Okay.
To mix with, to put it in perspective to what our dad's going through.
Okay. Well, that makes it very simple. And actually, I must tell you, the two of you actually sound a little bit alike. You've probably been told that before.
Yeah, that's what we're told.
Yeah, I can hear it. As soon as you started speaking, I thought, this voice kind of sounds familiar to me. Well, your sister is doing an incredible job on behalf of your dad. I just want to tell you.
Yes, she is.
And we see it, and I'm sure your dad's appreciative.
Yes.
And so, you definitely, she's in good hands. But I also should add that probably any assistance that she can get will help her too. So, as you probably know, we also have a caregivers call, and you are very welcome to join us on that. That's a little lower key than this call, if you like.
Okay.
We have good fun on there. Sometimes we see cats running around, dogs running around. We had a good time with Christine last week. So feel free to join us on that call.
Okay.
Maybe you or Christine, since you're here, I'm a little bit aware of the issues with your dad from that call, but Christine, maybe you want to fill in where you are now, or you, Jamie, where you are now with Dave, with David, and we can bat that around a little bit.
I'll hand that over to Chris.
Okay. Christine, Chris, we see you're on, but we don't hear you. Your
You
mic,
see my arm?
yeah, there you go.
You can see me?
No, we can't see you. Now we can hear you.
Oh, I thought you said you can see my arm. I'm like, oh no.
No, I said we can see you're on. No, we can't see you. Where's that cat? Where's that cat?
She's too hot today. It's 90 degrees out here.
Oh dear.
You sent the weather back here.
No, I did. Okay.
So let's see.
Yeah.
I did reach out to Dr. Friedlander.
Yeah.
I wanted to actually read exactly what the notes were.
What,
but I'll have
to just fill the guys in because they don't know what's going on with your dad, so you should probably just give them a quick update.
Okay, so my dad was on Xandy, and the PSA began to rise. He started it in March 2017, and his PSA was at 9.4. In April, it went down to 5. In May, it went down to 4. It stayed at 4 to the end of May. And then at the end of June, it started going up a little. But we were pretty steady at 4. But then in July, it went up to 5.8. And in August, it went up to 10. And then September, it went up to 15.8. But this case wasn't a regular case of taking Xandy because he was taking it at first full dose. Then after a few months, he got pain in his shoulder. So he went off it completely for a month to see if the pain went away. The pain went completely away. Then he went back on the Xandy at a lower dose. And then he went back on the Xandy at a higher dose, and the PSA just kept going up. So either the Xandy worked for either a very short period of time, or because of the lower dose over a 2-month period, maybe it lost its potency, but now we've stopped the Xandy and we're looking at new treatments. And now we're going to start chemotherapy.
Now, has your dad been on chemo before or not?
Yes, 2.5 years ago, he was on chemo for 6 cycles. And it seemed to work pretty good. So the doctor wants to put him on chemo again. He wants to use the same strain, which is Taxotere, docetaxel.
Right.
And then I also had sent an email to Dr. Friedlander to get his opinion. He said there were some studies that my dad could look into if he was interested, but my dad's really anxious and he wants to just start the chemo as soon as possible. He says he feels that the lymph nodes in his belly are, something's active in there.
Mm-hmm.
Says he can feel it.
Did you say that his PSA, the most recent PSA, was 15.8, right?
Yes.
Okay, and that was in October.
That was September 27.
Okay. And has there been any discussion as to whether your dad should return to docetaxel or to Jeptana, cabazitaxel?
Yes, he's returning to docetaxel. That's the chemo, right?
Right.
For 6 cycles, and he's starting on October 30th.
And Friedlander's on board with that.
Friedlander said that was an acceptable recommendation,
Okay.
but he did have other options.
But he had some other options. Did he lay out? I know your dad says he wants to get treated right away, but did he lay out those options for you at all or not?
Yes, he did.
Okay, can
So
you tell us what they are?
yes, let me grab that
Sure.
email really quick that I sent it. Oh, here, I think this is it. No, those are the bone scans. Shoot. Oh, here, maybe this is it. No. Oh, wait, here. Here it is. I found it. Okay, so open it. Okay, sorry about that.
No problem.
Okay, so I had emailed him and he replied that sorry to hear your PSA is rising. I asked him about the ARV7 testing.
Yeah.
And he said that he didn't find that to be very helpful and it was not a perfect predictor of response. Mm-hmm. And even if the folks who did respond, it tended to be a short response of 3 months or so. Mm-hmm. So he said chemotherapy is reasonable at this point, but obviously comes with a number of side effects, which you probably well know. He says we have a number of studies, immune therapy, genetically driven therapy, combination therapy with chemo, which I think you would be eligible for and are worth talking about. Mm-hmm. He says, can you not come to UCSF now? And he was even willing to reach out to his assistants regarding the insurance issue.
Right.
So that's where we stood there, but my dad wanted to just go with the chemo.
Well, you know, I think you know what I'm going to say to you, which is that you are way, way better off with Friedlander. Now, I understand because he's really laying out what's state of the art. So if he thinks that there could be some immunotherapy options, there could be some precision medicine options, or there could be some combination options with chemotherapy, it seems to me that those need to be explored at length before you jump into chemotherapy that may prevent him from entering a trial with drugs that otherwise could be exceptionally expensive, like $10,000 a month. Now, I realize that you can't switch your insurance until the beginning of next year. But it's clear to me that Terry Friedlander is reaching out to you and he's willing to work with you to try and figure out a way around this. And rather than dealing with a community medical oncologist who is really going back to a treatment that seemed to have worked once, but might not even be the best chemotherapy right now, because what's probably indicated is cabazitaxel rather than docetaxel, because that's why cabazitaxel was introduced. It was a second-line chemotherapy to be used second time around. I just, if it were me or if it were my loved one, I'd be wanting to talk to Friedlander. I mean, for the sake of a consult, which is going to cost you $400, I would go in and I would explore, particularly given that you're in the process of changing your insurance, and the likelihood is that come January you're going to be wanting to see Friedlander all the time, and it just seems far better to take his guidance right now. So that's
I completely agree with you, and there's actually a way around it insurance-wise.
right.
Trying to convince my father of that has been an entirely different thing.
Well, you know, if your father's concerned about his health and welfare, then he should be doing what is best for him. And what's best for him is to get some of the best docs in the country in this area acting for him, and not a local guy. I mean, I just got burnt last week with a local guy, and you know, some of these guys just they just don't have sufficient knowledge, and they're acting beyond where they're acting outside of their safe zones, and I see exactly what Friedlander is saying. It's acceptable. It is acceptable. To give him docetaxel again is very acceptable, but it may rule out a whole bunch of other options. And if it's docetaxel that he wants, and Friedlander can work out a plan, he can get the docetaxel from his local guy for the next month and a half. It'll be like 2 doses, and then he can move over. And you know, I think that if your dad wants people to help him and wants people to guide him, then he's got to play ball with them too. And this could be very significant, particularly if there are some good drugs out there and some good trials out there that Friedlander thinks he may go for. Now, I'm not saying you go into some sort of a double-blind random study at all. We're not talking about that. You know, your dad has to understand that you're not going to let him go into an unknown situation. I mean, in the worst case, he's going to get docetaxel, which he's happy with right now. But he may be able to get something a lot more than docetaxel, and he owes it to himself, and he certainly owes it to his daughters to explore that.
I know what I would do. This guy that we're seeing, he does not even specialize in prostate cancer. So he has not even seen that many cases. I've probably seen more cases than he has seen just by being in the support group, right?
Right.
So I agree with you 100%.
Well, I think you got to sit down with your dad and you know, make him understand, you know, how much you care for him and you love him, and the effort and the time that you're putting in, and you know, ask him to reconsider and at least listen to what Dr. Friedlander has to say.
Right.
Let me throw it open and ask some of the other people. Well, let me first ask Jamie. Jamie, where do you sit on all of this?
I'm with, you know, I guess it's kind of hard. I'm with you. I like I said, I told Chris she could do the research. She can offer the suggestion. And it's up to him to decide how to convince him. You know, all the options that Chris has researched are really good, but you know, I agree with her on that. It's the point of convincing him,
Right?
And that's the hard thing. And I'm not in his position. I'm not going through what he's going through. So therefore, I need to respect his wishes, but yet we do love him and we do have his best interest at heart. But getting him to feel that it's worth fighting for or taking the next step or going a different direction would, I'd like to see.
Let me throw it open to the guys that are on the call and ask them if they have any suggestions as to strategies that might be appropriate to raise with your dad or ways to talk to your dad. Guys, anybody got any bright thoughts here?
Rick, this is Dennis. I didn't hear the word Zytiga come up at all, unless I missed it. But I don't know why they wouldn't be suggesting that in light of all the studies, and that's what I've just gone on with my progression.
Well, I think the issue there, Dennis, and again, I'd be interested to hear other people, is that
I can hear you, Rick.
I think the issue there, Dennis, is that he's failing.
I'm not hearing you.
Okay. Can you guys hear me now or not?
Yeah, I think it must be on Dennis. It must be Dennis, because I can hear you fine, Rick.
Okay.
Yeah, we can hear you.
Okay. I think that since he's failed Xtandi and enzalutamide, there's a presumption that he's going to fail abiraterone, Zytiga. It's not automatic, and frankly, it might be a way to go to buy the couple of months that you need before you can switch your insurance over to if you need to do that, before you can switch your insurance over to UCSF. I mean, it's certainly an alternative, and it's something that ought to be raised with Dr. Friedlander. Go ahead.
I failed Xtandi, and then my doubling rate went up to one every 2 months, and then I started Zytiga, and it's been constant since then.
Wow.
So
thanks,
it's working for me.
So there you go, ladies. I mean, there's an issue. There's an example of somebody who doesn't make it on Xtandi, but does make it on Zytiga. So, maybe...
I tried that, and I tried to push it with the doctor, and he's like, there's no reason to try that. And then Dr. Friedlander said it might be successful, but he didn't feel like it really would be. But I asked my dad if he would try it, and he said no, he didn't want to try it.
Well, I mean, you've got somebody on this call. I mean, it's anecdotal, but you've got somebody on this call where it has worked.
Would you feel, versus treatments between chemotherapy versus Zytiga, would you have less side effects with the Zytiga?
I think that varies from person to person. But, for one thing, just like Xtandi, Zytiga is a pill. You don't have to go in and sit in a chair for 4 hours, and you have side effects from that. This is Jake talking, by the way. The side effects from Zytiga do vary from person to person. The only thing you could do is try it.
For me, it's just the hot flashes.
Hot flashes, yeah. That's pretty common with almost any prostate cancer treatment, unfortunately.
Well, when I was at the hospital for surgery, I didn't take my Zytiga, and my hot flashes were very mild. So I think the Zytiga definitely makes the hot flashes worse.
Yeah, that's what I'm saying. Almost any prostate cancer treatment gives you hot flashes.
And he did go through the chemo before, and he had neuropathy, which has not completely gone away. And he has some memory issues during the chemo, but now seem to be fine.
Well, that's all the more reason to try the cabazitaxel, because the cabazitaxel has a lower peripheral neuropathy profile than the docetaxel.
Really?
Yeah, that's one of the
Yeah.
advantages of. I mean, they're both taxane drugs, but supposedly it has a lower um, PNI profile than the docetaxel. Now, to answer your question about which has a lower, which has lesser side effects, so that was discussed at some length in the discussion that I referenced. I think it was last week on the Cancer Network or Urology Today. I forget which one. Between Alicia Morgan's Chuck Ryan, who's at UCSF, and Chris Sweeney at Dana-Farber, and they were talking about would they put a man onto chemotherapy or would they put a man onto second-line anti-androgens, and the consensus was that they would go to the second-line anti-androgens before the chemotherapy, but largely because men don't want to do chemotherapy. And so why opt for something they don't want to do when they're much more willing to take a pill? But I would recommend, Chris, that you listen to that discussion because they unpack that quite a bit. I think if I can find it quickly, I'll put it in the chat window for you.
Okay, that would be great.
Yeah, I see also.
Chris,
Yes. Go ahead.
Chris, I just have a quick question. If you said your father mentioned pain in the belly, is his mets moved into the soft tissue, or are they just in the bones still?
It's in the bones and it's in the lymph nodes, but it's been in the lymph nodes before, but the chemotherapy seemed to subside that.
But it doesn't show up. It doesn't show up in the liver at this point yet, huh?
No organs.
Okay, well, that's good. Because sometimes, guys that complain of pain in the belly, it's indication that, there might be something on the move in there. I've got a buddy here who's got that situation.
He doesn't have any pain. No pain, except he had some shoulder pain.
Okay, that's good.
So he doesn't even take that much pain medicine.
Good.
Yeah.
Does his blood work show he's still pretty strong and healthy?
Yes.
So that's another thing to think about, because I have a buddy here who got to the point where he couldn't go to chemo because his general health was so poor that he wasn't strong enough to endure the chemo. So sometimes using chemo as a last resort doesn't always work, and sometimes if it's offered earlier, even though it's your second round, it can have more advantage, and it won't wreak havoc on your body as much. Just a thought.
Thank you for your feedback.
Is there anybody else that'd like to contribute to this discussion? So Christine, I did put the link in there in the window. And by the way, Thibault also posted a link. I'm not quite sure what for, but we'll look at it and he'll tell us at some point. But 2 links in there. It's the second link, and what I think you just got to keep leaning on your dad and try and get him to, before he starts the chemo, to at least sit down. I mean, he owes it to his girls, if nothing else, to at least have one more discussion with Dr. Friedlander.
Hi, this is Chuck Ryan from the University of California, San Francisco. I'm joined today by Dr. Christopher Sweeney, Associate Professor at Harvard Medical School.
That's okay.
So I did have a quick question, if
Yes.
I can ask to anybody out there. My concern was, what was the urgency in him starting the chemo right away, or could he wait 2 months? Would he get worse in those 2 months before his insurance took over so he could go to UC Davis?
You know, I mean, I think that's a question you've got to ask Friedlander and you've got to ask the doctor. I mean, that's very much a medical question.
Okay.
You might want to. I mean, I want to throw it open to the guys because they've been some of the guys on the call have been in this situation. You know, my response would be, look, the PSA is on the move, probably needs some change of treatment, and if he doesn't want to start the chemo right away, then maybe abiraterone is an alternative that might hold it in bay, just like it did for Thibault. But he probably needs to do something, and I'm not sure it would be a good plan just to continue as is for 2 months. But that's definitely a question. If you get to sit down with Terry Friedlander, that's definitely a question for him.
Okay.
Anybody else want to respond to that one?
It's Larry Fish. I have a question. Is he stopped taking Lupron? They're not considering Are they continuing Lupron shots, or that's not in the picture?
He's still on Lupron once a month, and he's also on Xgeva.
Okay.
Okay. Okay. Okay. All right. So I'm gonna go down my list, and I think yes, we have one person that's joined us on the phone. Would you like to tell us who that is?
Yeah, sure, Peter. John Appler here. I'm sorry I'm late. Just got done with my treatment.
Okay, John Appler. Thank you. And then I think we had somebody who came on and left whilst we were talking to you. So
yeah, we did.
Yeah, somebody called Mr. Hoffman I saw, but I don't know. We haven't heard from him before, but maybe he'll come back. He's more than welcome. All right, so I'm going to go down the list, and I'm going to see who would like some time today. Jake, have you had your discussion with your doc?
Yep, I saw her last week. I told her I was on. I had upped my dose of metformin. She says, "Oh, okay," and that was it. She didn't care. Okay. We'll see if it helps.
Let's review with you. We'll come back to you for a short one. Dennis, anything for you?
Yeah, I'll give a quick update.
Thank you. Peter, anything for you? Peter?
Okay. No, I think I'm fine. Nothing today.
Okay. Jay Krugman, anything for you?
Nothing this evening, thank you.
Thanks. Joe Blanchette, anything for you?
Yes, I have a question.
Good. Paul Frieda, anything for you?
Nothing for me tonight, thanks.
Okay. Sylvester, anything for you?
No, not this evening. Thanks anyway.
Larry Fish, anything for you?
No, and I'll have to jump off in about 15, 20 minutes. It's a lot. Nothing to say.
Sorry, well, I missed that. I've got to.
Hang on, Rick. Peter, I'm gonna mute you because we're getting noise from you. Okay?
Yeah, it sounds like the Hawaiians are beating the drum. The Mauians are beating the drum in the background there.
Yeah, we'll check back in a minute or two to see if you're still making that noise.
Yeah, thank you. Sorry, Larry, could you repeat that?
Yeah, nothing tonight, and I'm gonna have to jump off about 7:10.
Okay. Well, thanks for coming.
But and I wanted to just say something to Thibault that, even though we may not say anything to you, I think that all of us, we're all with you as we are with each other, and caring and hoping for everybody. And that's all really I wanted to say. I thought about this the other week, that not everybody's speaking, but we're all together, and we're all hoping and praying together and thinking for all of us, I think.
Yeah, well
Yep.
said.
Well said. I think we're all in the same boat. We all think the same thing.
Yeah, absolutely agree. It actually raises something, if there's time, that I want to discuss tonight. And John Appler, how about you? Would you like to talk about anything tonight?
No, Peter, I agree with the guys that it's great to listen and learn, and I hope the woman who spoke can get through to her dad and just think about how she would feel years from now if she hadn't tried her best to convince him. So I hear your pain, and thanks for just letting me listen and learn, and I'm fine. Thank you.
Good. Okay, so we probably have quite a lot of time tonight, which is good. Jake, why don't you tell us about this, about your visit with your doc?
Okay. By the way, Peter, I unmuted you. We don't seem to be having the sound, so you can talk if you want to. Yeah, I went to my oncologist for my regular monthly visit. Got my Zometa shot or infusion, and I got my Lupron shot. And I told her I had changed the medication. I increased my metformin from 500 milligrams to 1,000 in coordination with my primary care. And she said, "Oh, okay." Then that was about it. I don't think she ever thought that it makes a difference anyway, so she doesn't really care. She goes, "Well, you're diabetic anyway," and I go, "Well, I'm pre-diabetic. I've never been over 120 officially. When I've been tested at a doctor's office, and my A1C's always been good. So, but anyway, she knows about it. She's on board. She didn't say anything, Rick, about my calcium, which was low again this time. I got another blood test, and my PSA is still low. It actually went down from 0.6 to from 0.6 to 0.5. And my testosterone, I'm definitely a eunuch. My testosterone is at its lowest at 24. That's lower than it's ever been. And that is on the Xtandi. I've been taking the Xtandi now for about 8 months. And thankfully, so far, it's been working for me. So that was about it. She seemed happy with the results.
Did you ever follow through with anybody on getting your vitamin D, D3 Hydroxy-25 tested?
No, I completely forgot about that, Rick. Neither of my doctors has mentioned it. They both see I share the blood results. Well, the one orders the blood results, and the other one I share with, and neither one of them has ever said anything about D3. So all I do take a supplement every day, a calcium and vitamin D3 supplement.
Yeah, I think you should ask them. I do, because if you're low on D3, and you may well be low on D3, it helps you to absorb calcium if you bring it up. And it's a pretty benign vitamin. So you can be taking 5, even 10,000 a day. Some people do.
Okay, so, yeah, I completely forgot. I do know one thing, Rick. I found out doing a little bit of research, because some of my readings were low this time. Calcium was one, my protein was low, and my creatinine had gone down. And so I looked up a couple of those things, and something that I saw was that a beta blocker, if taken within 2 hours of the vitamin D3s, will reduce the efficiency of the vitamin D3. So I've started taking it at a different time. I've tried to separate them, and I'll see if that makes a difference. But next time I go to her, I will ask her about it, the D3 part.
I think you just need to get your D3 tested. I mean, if nothing else, just ask them, just ask them, would they be good enough to put in an order for D3 Hydroxy-25?
That's a blood test?
Yeah.
Okay.
Yeah, D3.
Well,
anybody else want to talk about their experience with D3 on the call?
I know that taking it does raise your level. I had low D3 and took it for a long time, and it got higher.
Right. I mean, it's pretty common in men who have prostate cancer that their D3 is really low. I think mine was about 18 or 20 when I was diagnosed, and it now runs around 50 to 60. And
low D3 lowers your calcium. Is that is that what you're saying?
D3 assists you in absorbing calcium amongst a bunch of other things. It does a whole bunch of different things. But one thing it does do is it helps you absorb calcium. And we know that, you know, higher levels of D3 seem to be more positive than lower levels. But I can't tell you more than that. But there's a lot of information out there, but it's not good to have low levels of it's not good to have low levels of D. And you know, if you don't see the sun very much, which I know you don't, you're not going to get any D from being outside. I mean, most people will get vitamin D from just being in sunlight between February and October.
Right.
Between October and February, the sun's too low in the sky to give you to help your D3. But it does promote your D levels, and I think it's. I mean, for me, it was important to get it up, and I mean, as you heard, Thibaut also brought his up, and I would guess that most of the people on this call at some point or the other have tested their D3 and have taken D supplement.
Well, how do you get it up other than diet and sunlight?
You take a supplement.
Well, I am taking a supplement.
Well, but maybe you're not enough.
Oh.
How much are you taking?
I don't know. Let me look.
Yeah, this is Joel. When I was diagnosed, I had a D3 level of 20. I then started taking 10,000 IUs a day. I went up to 113, came back down to 69. Now I'm at 89, still within the range. 113 is about 13 points above the range.
Right.
I don't know if it's helping me any, but anyway, I think Rick is correct. There's more positive things that happen with high D3 than low D3.
And Joel, how much are you taking now that you've got it in the range?
I'm still taking the 10,000 IUs a day. I take one in the morning, one at night, and I can't explain why it went from 113 down to 69. I have no explanation for that whatsoever. Same brand, same everything, and I don't know what changed in why that score went down. Now it's on the way back up.
Okay.
Is that just D3, Joel?
Yes, just D3. I think it's a Nature Made brand that I get at Costco.
Okay. Yeah, to answer your question, Rick, I take a combination calcium, 600 milligrams, and vitamin D, 800 IUs.
Right.
I've been taking one a day.
Right. So, you know, you can go quite a bit higher. I mean, at one point I was taking 2,000 a day, and then I cut it down to 1,000. And then, you know, once my range was in the, I mean, they like your range to be in the 40 to 60 area. I mean, that's from what I understand. And so once I was in that area, I kept cutting it down, and now I'm down to 400 a day, and I maintain on 400. But you know, the thing is, you have to keep testing so that you know where your levels are, and you can adjust how much you're taking with your levels. I'm not sure why Joel is bouncing around like that, but you know, many men will adjust. Anybody else have any experience with D3?
according to Dr. Snuffy Myers, he says the way to check if you're taking too much D3 is that your calcium level and your blood test will go up, will be too high. If your calcium level is okay, then you're not taking too much D3.
Okay. Well, my calcium has been low. That's the one thing they do. She does measure each week or each month, and it's been low now for at least 2 months.
Well, you know, I would talk to her about measuring your D3 and maybe taking a larger supplement. You know, keep taking your calcium D3 and then just add a D3 supplement. You can get it at CVS or wherever. You know, you get it on sale, 2 for 1. That's I always go in and buy when there's 2 for 1, and you can get it in all kinds of doses from 400 right up to 5,000.
Okay.
So there are, you know, you just select the dosage that you want, and it's
that's easy enough to do. I will do that.
And it's hard to OD. I mean, you really can't. You know, you can take up to 50,000. So it just may solve that calcium issue and help you right the way through. Now, I have very high calcium, so I don't take it for the reason of absorbing calcium. You know, that calcium would not be a good measure for me personally in terms of whether I'm taking too little or too much. But that's just my own chemistry.
Well, that's why I've been hesitant to take more of these combination pills. I didn't realize they came separately. You did tell me they came separately.
Yeah.
But I didn't want to take more of the calcium and vitamin D combined because the calcium has an issue for your heart.
Okay. So, you know, just go get the generic brand or the Costco brand or whatever you want to get, but get it because I mean it's worth following up on. Jake.
Will do.
Okay.
You could also get more sunshine too.
That I could do. Even though we're getting closer to wintertime, but yeah, we still got another month or so of sun.
Well, you know, they do, like I said before, forgive me for repeating myself, but they do say that once October comes around, the sun starts to get too low for you to get the benefit of the sunshine. So,
Oh, I thought you said February.
Oh,
it's October. October to. Oh.
Sun is too low in the sky from October to February to really give you a benefit from being outside in the sunshine. In where we live, that may not be true in Hawaii, I have to say, and I doubt it's true. I doubt it's true down here in southern Arizona, but I'm not sure about that. I can tell you it's pretty strong.
If it's true in Arizona, then for sure it's true in Maryland.
Okay. All right.
Thank you, gents.
Pleasure. Anything else? Anything else you wanted to bring up whilst you had the floor, Jake?
No. We got some family issues. You know, that has nothing to do with prostate cancer. My wife's brother-in-law and nephew both shot themselves on Saturday night. Yeah.
Oh my gosh.
Oh, tell me about it. So my wife is out of town. She's in Wisconsin staying with her sister. Oh, and my son went with her. So.
Oh my.
Very unexpected. It's quite a shock. You know, the son, the father was. This is my sister-in-law's ex-husband. He was 60, and the son would have turned 30 this week. He would have turned 30 on the 26th of October, and he shot himself first, and then his father came up, saw him, walked downstairs, and sat down in a chair and shot himself. So that's.
Any idea what the depression was all about? Financial trouble, or?
I think that they were fighting constantly. The father and the son were fighting constantly, and the father would belittle the son. 800 miles away, it's kind of hard to know exactly what happened. But yeah, I think there was some internal stress or strife, and then financial problems were probably the icing on the cake. Because he came up and talked to his mom, and she was getting ready to go to bed, and he says, "I love you, Mom." Walked out of the room and shot himself in the doorway. He says, "I love you," and walks out and shoots himself. So, as you can imagine, it's quite a shock to the whole family. My wife is devastated, and we're worried about her grandmother, or their mom, who's 87 years old and already had a stroke. We're worried about the effect it'll have on her. So my problems are minor compared to them right now.
I'm so sorry to hear that. But, Jake, talk to us. If you feel like you need to talk, then there's a whole bunch of us here that are happy to talk to you. You can pick your poison.
Thank you.
And,
Thank you, Rick.
And when's your next inner conversation?
Thursday.
Oh, there you go. So that'll be a good call for you to be on.
I'm the moderator, and I'm the one with the problem.
Well,
but yeah,
I think we can. Let's see what we can do about that too. Okay. Because you need to do some talking, and you need some support, and that's kind of hard when you're the moderator.
Well, I'm okay, Rick. It was my wife's sister. The father they were divorced. They were still living in the same household, but they were divorced. But it's the son, the nephew, that's the shocker. Such a young man. Very smart, very personable. Had the whole world in front of him, and that's the shame. That's the sad part. So, personally, I'm okay. I mean, it doesn't affect me too closely. Because we didn't know them. I didn't know them that well because they lived 800 miles away in Wisconsin. And as you know, I don't travel. So I would only see them when they came to visit us. And that was very, very infrequently. But my wife is the one with the trouble, the problems, and her mother. And of course, the mother of the son that killed himself.
Yeah. That's her sister, right?
Yeah.
Okay.
I know. Horrible.
It is absolutely horrible.
Okay, enough for me. Talk to somebody else.
Okay, Dennis, step into the breach.
Yes, I just wanted to update everyone on, been on Zytiga and prednisone now for about a week. And I got to say, it's the first cancer drug treatment that didn't make me feel worse once I started taking it than what I felt before. So far, so good with this week. I actually think the little bit of prednisone I'm taking, 2.5 milligrams twice a day, are probably helping with some of my other aches and pains and inflammation that I have. Went out for a little longer walk this morning than what I've usually been doing, and no adverse results. So, and I will be getting a blood draw this Friday and reviewing that the following day, I believe, with my doctor. So we'll see what kind of results I'm getting. I don't know if I'm too optimistic and expecting to see a quick drop in PSA and no adverse influence on other things like liver, kidneys, heart, and so forth.
Well, we're all happy to hear that you're doing well. You feel like you're getting some side benefits from the prednisone. That's really positive. How will you review? Are you going to go up to Phoenix to see Dr. Singh, or are you talk to him on the telephone, or are you using the local doctor? Where are you in that?
Yeah, I'm using the local doc, and I will be, getting my blood draw here, getting some local counseling from him, and if there, any major decisions, and probably at least on a 6-month basis, I'll be going back to Mayo to Dr. Singh.
Let me just. I'm we're getting some feedback for some people. So if you find
Yeah, I already muted Peter. If you could mute yourself if you're not talking on the phone, please do so, because we're getting a lot of feedback.
Right. Yeah, I've got to Peter and to Joe Blanchett.
The problem with us muting somebody on the phone is they can't tell us they want to talk.
Right.
They can't send us a message saying, "Can I talk now?"
Right. No,
So Peter, can you mute yourself?
Peter just unmuted himself. But Peter's fine, except every so often we kind of hear these Maui drums in the background. I'm not quite sure what that is. It could be the grandkids beating on the back of the truck or something. I don't know.
I hope there's not a big black kettle in the backyard with some natives dancing around. That might not be too good for Peter.
You're absolutely right.
No, I know what it is. It's when I get a text during the call. It makes a noise, but I've got myself muted most of the time.
Oh, I see. Okay. Oh, it's those jungle drums indicating that you have a text coming through, eh, Peter? What's the name of the doc that you are using in Tucson?
He's with Arizona Oncology, and it's another Indian name, and I'm Rafiath, Rafiyaath.
Okay. And you like him? I assume you've met him already.
Yes, he was very personable. Took a lot of time with us on our first visit.
Good.
Explained everything very thoroughly, answered any questions I had, and gave me the results from the tumor board at Mayo. He went over that with me in detail.
Great.
So, yeah, just hopefully this is going to work for me.
Right.
And both the standpoint of getting my PSA down and not giving me any extreme side effects that I can't deal with. And so far, I'm not seeing any difference. I'm still getting hot flashes. I'm still getting Lupron.
Right.
But I don't think they've gotten any worse. And nothing else that I can say. I just actually feel a little bit better, a little more flexible, I guess.
How's that golf game? How's that golf game on the prednisone, Dennis?
Well, I haven't had an opportunity yet. I didn't play yesterday.
Okay.
So, but I will be playing Thursday in Tubac.
Oh, are you going to stop by? Hello? I'll talk to you later. I'll call you after.
Okay.
Okay.
Sure.
Do you feel that Rafiath is comfortable working with Dr. Singh?
Yes, they've known each other. They went to school together.
Good.
And so they are on the right. They've got the right connection.
Good.
But they respect each other. And
good. Okay. Well, I will definitely give you a call later on. Maybe we'll be able to get a drink or something afterwards, or you'll stop over here or something. You're gonna go past my door anyway. So, literally past the door.
Okay.
So let me see. Joe Blanchett. Oh, well, I'm sorry. Did anyone want to talk to Dennis? Any discussion with Dennis about the abiraterone or the prednisone or anything else? Ideas, thoughts? Anybody want to say anything?
Have you had a PSA test yet, Dennis, to see if the abiraterone helped?
No, I don't. That'll be Friday. I get my first blood draw. I only been on it for a week, so.
Okay, right. Well, great. Best of luck. I hope it works.
Okay.
Yep.
What's your D3, Dennis?
Don't remember, but I've been on a calcium D3 supplement pretty hefty dose. Since I got my original diagnosis, I knew I was going on ADT, and they said if you're going to be on ADT for any period of time, you better get this for your bones. And my calcium level has always been good. I don't remember specifically what the D3 level is, but I know the calcium has always been good. And I think I will be getting scheduled fairly soon for another bone density scan.
Right.
Which I did initially, again, after initial diagnosis, I got a baseline. So I'll be following up with another one.
Yeah, I mean, I do recommend that everybody checks their D3 at least once a year. The test
is there, Rick, on the blood test results? They always use abbreviations. Does it say D3 or is there another abbreviation?
No, D3 Hydroxy-25.
That's what it says on the blood test.
Yeah, D3 Hydroxy-25 is the test. I'll put it in the chat window. But yeah, I mean, I do recommend that, especially those of you that get tested regularly. I would suggest that you do check your D3 every so often, and then regulate it if it's out the range. I mean, I think some of you might be surprised that you're low, and you know, it's the doctors don't mind you. They don't mind testing it, and it's just a simple thing to do, and it you know, it can't hurt. So, just mentioning. Okay. Let's go on to Joel Blanchette. Joel.
Yes, question for you. Can you recommend a genomic counselor in the DC area? Or if not, where to go to find a good one? Do you have any recommendations? I know there are not many around, and there's even fewer technicians that can test for genomics, but counselors are few and far between.
Right. I don't know. Is Thibaut with us or not with us, or in the land of Nod? Looks like he's in the land of Nod. Because he was
here. Yeah.
Somebody wanted to say something?
Thibaut's still here. He's on. He's online.
Hi. Hi. Any thoughts on where to find a genetic counselor in the DC area?
Well, the genetic test that Dr. Antanarakis had me do is called Color, C-O-L-O-R. And he said my insurance wouldn't pay for it. I paid for it myself. It was only a couple $100.
But was that a germline test or was that a somatic test?
It was.
Did we just lose Thibaut?
I think he froze. His screen and microphone froze up.
We think you froze. You're looking very red and toasty in your picture, Thibaut, but we think you froze. So, Joe, I think that what you're considering is a germline test. And I would recommend a couple of things. I would recommend that you, I mean, I don't know how convenient it is, but I'm almost certain there's going to be a bunch of counselors at Hopkins, but Baltimore may not be convenient enough for you. In DC, I would think that George Washington probably has genetic counselors. Have you checked George Washington?
No, and John Hopkins is not too far for me. It's only about an hour away from that. I'm willing to go 200 or 300 miles if I have to. I'm also considering the Garden 360 test,
Right.
but the blood test only. They don't need the tissue test. For the germline test, they need the tissue, I believe, to test.
Another one you might want to try is University of Maryland. I think there's one in Rockville.
Okay.
I found the test that Dr. Antonarakis did on my tumor from the prostatectomy. It says PGD Cancer Select Report.
Right, but that is a that's going to be a somatic test, and I think what Joel is looking for is the germline test, which is what Peter did and others have done, which shows what sort of inherited genes you might have. Is that if you're not looking for a germline test, Joel, you don't need to see a genetic counselor.
Okay. Yeah, I am looking for the germline test for sure. I just wanted to know if there's any other genomics tests that I should be taking, given the fact that I'm at 0.2 PSA and I'm biochemically recurring with prostate cancer. So I just thought that so far all I've taken is the Decipher test, and the Decipher puts me right in the middle, intermediate.
Right.
So it's not aggressive, low range, but just trying to find if there's another test that could help me make a decision of what's next.
Right. Well, I mean, I would, if it were me, I think I would probably, especially given that you have a significant family history, I think at this point I would just be looking at a germline test. I don't think you probably need to go to a Guardant or to one of these more sophisticated tissue tests. And so that's just a swab or a depending on who does it, a swab or blood. But you do have to get genetic counseling with it. And I would say that probably should be available through one of the university hospitals.
Okay.
Now, who is your who are you seeing on a follow-up basis for your cancer?
Well, I'm seeing my original urologist surgeon who took my prostate out 6 years ago, and I'm also seeing one of the prostate cancer support groups that I go to is at Reston Hospital. And the people who started the group were the doctors there, the urology group at the hospital. And so I've had 2 or 3 doctors counsel me also from that group within the prostate cancer support group. And I've also have gone to see one of them, and one of them briefed last month, and I asked her specifically, if I come and see you as a patient, will you give me the germline test? And she answered yes. So I can go there and she'll order me the test.
Okay, and what sort of doctor is she?
She's a urologist surgeon also.
Okay, but you know, I have to say that, you know, in an environment of possible recurrence and a rising PSA, if it were me, I would not be seeing a surgeon. I would be seeing a medical oncologist that specializes in genitourinary disease.
Okay.
And all too often, the surgeons want to get in on the act of recurring disease for what I don't really understand why. I mean, I don't want to sound cynical, but it could be financial, but it isn't only financial. I mean, there was a recent, for those of you that follow Mike Scott, he recommended a discussion between Chuck Ryan, Alicia Morgans, and 2 surgeons recently. And I wrote in the note that I would disagree with him, and I would recommend that people listen to the discussion I referenced online earlier between Scott Sweeney, between Ryan Sweeney and Morgans, because both those conversations were published in the same week. Now, I feel quite comfortable in saying that I doubt that Ryan's and Morgan particularly wanted to have the discussion with the surgeons, because I don't think they would agree that surgeons should be running advanced care. But politically, they're in a very difficult place, and they're basically obligated because there's a lot of pressure from the AUA and others to allow surgeons to treat recurring and advanced cancer. Now, surgeons are not trained in internal medicine. And so many of the issues that surround the treatment of advanced prostate cancer involve internal medicine. And if they wanted to be treating advanced prostate cancer, they should have been internists and they should have done their boards in medical oncology and not in surgery. So that's my 2 cents, and I think you'd find, Joel, that most people on this call would support the fact that you're better off with a genitourinary medical oncologist than you are with a urologic oncologist, a surgeon. In the area where you are, there are some options in DC, but probably your best options are at Hopkins. And at Hopkins, I would say the best option is Antanarakis, if you can get in to see him, who's Thibaut's doctor.
Can you spell that?
Yes, Antonarakis.
Thank you. Also, who would it be best, Dr. Snuffy Myers or this guy you just recommended?
Well, first of all, Myers isn't taking anybody.
Okay.
So you can't see Myers if you wanted to. Secondly, by far and away, I would recommend Antonarakis over somebody like Snuffy. But I have a bias, so I have to declare that. But I think that you are way better off in a center of excellence, by and large. Not always, but by and large, you're better off in a center of excellence than you are with an independent GU med-onc. There are some exceptions. You know, I think that sometimes PCRI docs are really good, but I've also seen recently where they will tend to overtreat. And it's a concern to me that the independent, this is my own personal concern. There are people that will disagree with me probably on this call right now, and I'll give them a chance. But I just feel that the independent guys tend to overtreat. And that to me is as bad as overtreatment for active surveillance. So
I also think that Snuffy Myers is pretty much retired. I understand he's out of the business now.
Yeah, he is. Well, he has Parkinson's, and you know, he was pretty shaky when we saw him at PCRI. So you know that's Antanarakis is good. There are a couple of doctors there that I would avoid at Hopkins that I'm not a fan of. One is Carducci, Carducci. I mean, he has a good reputation, but I just don't like the way that I've seen him interact with patients that we've supported here, and that bothers me. But I'm sure that there are people that like him a lot. But if it were me, I wouldn't want to be seeing Carducci. So those are a couple of thoughts for you, Joel. But you know, it's probably a good time for you to get in to set up a GU med-onc as your quarterback going forward.
Okay, I agree. Yeah, I agree.
So let me throw it open so people can shoot down what I said.
This is Peter. Can you hear me?
We can.
Okay, well, my experience was I didn't particularly go through the docs at UCSF. I just made an appointment with their genetic testing area, and I had a counselor there, and I had to pay $90 up front because it wasn't covered on insurance for the counseling session. I filled out the paperwork. I had to do pretty extensive paperwork about family history and so forth, parents, cousins, aunts, uncles, and so forth. And once that was done, they just did. I did that ahead of time, and they just did a saliva swab, and sent it away to Embry Labs, and I got the results back, and I didn't have to go through the doctor per se on that one. So it was pretty simple, and everything was covered by insurance except for the counseling session, and that was $90, I think.
Thanks, Peter.
The germline test covered by insurance, does anybody know? And how much is it if it's out of pocket?
Mine was covered by insurance. The only thing that wasn't covered was the $90 consultation with the genetic counselor. That was the only thing I had to pay up front, and that was at the UCSF.
Okay.
So I think you probably want to go through a genetic counselor because you'll need to have the thing interpreted as well. It's not that it's a little bit complex if they find something. But for me, they found a gene mutation that wasn't necessarily related to prostate cancer, but it has some relation. But it had relationship to other things.
Right.
Okay. You know, with a history of a father and grandfather with prostate cancer and a mother with ovarian cancer, Joel, I don't think you'll have any issues having your insurance covered.
Okay.
I mean, you know, we're not docs. We can't give. This isn't really medical advice, but financially, I know that when you've got a strong family history like that, there's never much argument.
Okay. I appreciate it. Thank you. I learned a lot tonight.
Sure. Anybody else want to chip in on that or on surgeons versus GU med oncs for advanced treatment?
Hey, Rick.
Yes.
Just a quick question. You know, I understood from my doctor that it was too early for me for genetic tests because if my treatment failed, then my cancer would probably change, and it's a new cancer that you want to get a genetic profile of. And yet, it sounds like also when you look at some of these sites like you referred me to, like Emerging Meds, they really want to know the profile of your current tumor in case there is a trial coming up to knock it out. So would you say that this germline testing with any family history of any cancer would be something you should do immediately regardless of the stage of your cancer?
Well, germline testing has nothing to do with the stage of your cancer. So whatever germline mutations you have are kind of like a baseline. And if you think you have, if you feel that you have a history of cancer in your family or other diseases, then yeah, there's no reason why not to do a germline test. I mean, a really good example of that is Professor Bill, who had a huge amount of cancer in his family. Aunts, uncles, goodness knows what. And that was what encouraged him to do a germline test early in the game when he was diagnosed with metastatic prostate cancer. He was already diagnosed metastatic. And that's when he found out that he was BRCA positive. And that was an important result for him. So I would say that if you have a family history, then definitely it's worth pursuing. Having said that, it's a different situation if you're looking at somatic testing. And the doctors there are right. I mean, there's not much point in doing somatic testing early in the game. That's what we just said to Joel, that probably it's too early to consider somatic testing. like the garden test. But the germline testing does make a lot more sense. Does that answer the question, John?
It does, and I assume that means then the germline testing would there's not like a hook and key that would tell you if you had both your current tumor tested and you also had your germline, test to determine history there. If the combination of those two data sets might find, why I have this cancer now and allow a treatment, or are you saying the two don't relate? One does not, germline will not predict.
That's a question for Bill. I mean, I think Bill could probably go down at some length. But what I would say is this. I mean, we've talked quite a bit about where the crossover is between somatic and germline in the past. Foundation Medicine runs a test for BRCA, I think, and they can identify if you have BRCA, whether it's from germline or whether it's from somatic. But they can't tell you whether it's germline or somatic. And if you ask them, how would you tell? They say, well, you'd have to do a germline test. Now, I don't know enough about the technical aspects of these tests to tell you how they differ, but they definitely do. I mean, the method in which the test is run is obviously different. But I don't know where the crossover is, and I don't know what the likelihood is that somebody would develop a mutation somatically that they already had inherited, or if that even happens.
From what I understand, and Rick, I'm sure you know more about this than I do, but if you have a mutation, that's bad and it's good in the sense that if you have a BRCA2, that's a sign that you have possibly more aggressive prostate cancer, but you can then you can wipe it out with a drug like olaparib.
Right.
And so the people who have no mutations basically have to go with the one-size-fits-all type of technology or medicine. If you do have a gene line mutation or a gene repair defect, then with the individualized medicine that they're aiming for today is that there are drugs that can attack those with the mutations.
Right.
Yeah, makes sense.
I think the issue, let me just respond and then I'll come back to you, John. I think the issue that John's raising is, what about where that mutation comes from? Does it come from inherited germline, or does it come from you making it yourself within your own body, which is the somatic, somatic origin? Now, the person and whether there is a difference if it's somatic versus if it is germline. There's no question that either way you could still use olaparib, a PARP inhibitor. But I don't know whether you'd respond differently if you were somatic or if you were if it was inherited. And the person that would know, and he's not on the call tonight, is Bill. And if you make a mental note of that, John, and you and Bill are on the call at the same time, please raise it, because I think Bill probably has better insight than most, including most doctors, because this is a field that he's devoted his life to.
Yeah, sure will. And that's Bill Bornstein, I believe.
No,
Rick, is that correct?
No, that's Bill Burhans.
Burhan.
Yeah, Bill Burhan.
Got it. Thank you.
Yeah. I'm Joe. Please go ahead.
No, that's it. Thank you.
Okay. So anyone else want to discuss this issue of germline and somatic testing? Okay. So
well, I think there is some value, Rick, in this. If you know you have their presence in your family, and you want to know if you're a carrier of this, if you have children or sons or whatever, it's just one more thing that you can clarify your mind on. Standpoint of advising your children relative to the degree of testing or reviews that they should be doing for themselves going forward.
Right. Right. I mean, I think Dennis raises a really good point, but one of the reasons why a genetic counselor is involved in the process with germline testing is because sometimes you uncover things that you weren't expecting, and you have to know how to deal with that, both for yourself and for your family. And the genetic counselors are trained in helping you. Peter, do you want to comment on that?
Yeah, it gives you a heads up. For me, it gave me a heads up on a disease that's where I can actually take some aggressive action in terms of testing every year, because all of a sudden my susceptibility to colorectal cancer went up to 50%, and I had no idea. So I was under the idea that, well, if I go every 10 years for a colonoscopy, that's okay. But they said no. The recommendation now is you should really do this every year, and that's kind of an invasive test. But heck, if I've got over 50% odd of picking up something like that on top of my prostate cancer, big deal. I'll go for the colonoscopy every year. So it's I see it as helpful information. I wasn't expecting it, but that's what came back.
And
they're always finding new things too. I mean, this is genetic testing is a really emerging field. It's not it hasn't been around that long, and it's developing rapidly.
And how did you deal with it with your boys, Peter?
I talked to them and I wrote them a letter, and it's more a question of how they're going to deal with it. As I said on my call yesterday, I was talking to my son the other day, my older son on the phone the other day up in Canada, and he finally shut me up and said, "Okay, that's enough talk about prostate cancer. I don't want to hear anymore." So it's at least they're aware of it. They're aware of things. I make sure that it's in writing, and I make sure that they know. But it's really their responsibility now. They're adults. How proactive they want to be is up to them. They're not little kids anymore.
Peter, do you think they were grateful when you advised them about the fact that they had a high risk for colorectal?
Oh, I know they're grateful. I don't think they're holding it against me, but still, younger people who are healthy, and don't want to think about sickness too much. So I don't want to make them paranoid or whatever. They might never come down with prostate cancer, or never come down with colorectal cancer or anything, but at least they have the information going forward, and they know that they should get tested, and now that they're in their 40s.
So, I think the take-home message with all of this is that if you have a genetic history in your family, or if you have a history of disease in your family that makes you wonder whether there may be some sort of a gene defect, and it doesn't necessarily have to be cancer, but if there's repeated disease in the family for, a couple of generations and across laterally, with cousins or with uncles and with aunts, then there's good reason to do germline testing, because to be forewarned is to be forearmed. And if you find out that you're at risk for a particular disease before it strikes, there may be things that you can do, as in Peter's case, where they told him that he has this, I think it was MLH1, which is a gene defect associated with Lynch syndrome, which causes all kinds of different cancers, including, by the way, that there is some association with prostate cancer. It's not that high, but particularly, as Peter said, with colorectal cancer. Then there are things you can do, like scheduling a test a lot more often. It's not, as Peter says, excuse the pun, it's a pain in the ass to get that test once a year, but it's very worthwhile. So, anybody else like to comment on this germline testing issue?
Rick, have you heard anything about the breast cancer genes they just identified? I think 70 some more genes.
No.
Associated with. Yeah, that was heard in the news yesterday. I really haven't looked into it any further, but it sounds like a large number is being added to the list that they already have. And, how will that eventually play in with knowledge of which of these are having an effect on prostate cancer?
Right. Well, as we all know, there is a huge similarity between the physiology of breast cancer and the physiology of prostate cancer. So if you see a defect, gene defect that's common in breast cancer, it may well apply to prostate cancer too. But no, I haven't heard anything about it. I will, by the way, mention that we're about to start on November 2nd the male breast cancer call. And we are hopefully starting a female breast cancer call in the UK in the new year. And I just this morning spoke to a moderator who is willing and has expressed interest in moderating a female breast cancer call. So that's pretty exciting. If you know people that fit into any of those three categories, then we may have a call for them before too long. Okay, so I think we've covered everybody who indicated they wanted to say something. Is there anybody on the call that would like to raise anything? I have something I want to talk about, but I want to defer that in case there's anybody else that would like to talk. Okay. So this is sort of falls into the topic of my wanting to get something off my chest. And it's not a frequent problem, but it's a problem that has occurred before and will occur again, almost certainly. It leaves me a little uncertain how to handle, so I feel it might be a good thing to air on this call. And ironically, something similar happened a second time today, right before the call. But you probably saw that I alluded in the notice this week to a bad situation that arose during the week where one of our regular guys who was diagnosed with a very nasty situation wanted to get somatic testing. Now, he had a local doc, and he also has a lead doc at one of the institutions of excellence. And the local doc is a community medical oncologist. The doc at the Center of Excellence expressed to us, both in writing and in a telephone conference, that he thought it was really important to get the sequencing. For this particular guy, there were 2 biopsies involved. So we asked the local doctor to do it, and the local doctor poo-pooed it and said, oh, you don't need it right now. We're going to give you chemotherapy. Let's see how you do after several weeks. And That bothered me right off the bat because it's not 100% clear how chemotherapy might affect prostate cancer cells. At first, I remember asking this question about 3 years ago to Chuck Ryan and Eric Small in an open forum, and both of them said, it was right at the time when Charted came out. It was probably about a month after Charted came out, and there was a big open forum at UCSF, their research day, which they hold every year. It's coming up this year on November 8th, and I'll be there. And I got up in the forum, in the plenary, and I said, what do you think will happen to these prostate cells if they're exposed to early chemotherapy? And the answer was, well, we don't think it'll happen. Nothing much will happen. We don't think it changes. Over the past 2 or 3 years, that seems to have changed quite a bit. Now they're not so sure. And it seemed to me that here was a guy, my guy, coming back to the present, who hadn't started chemo yet. And if we were going to test him, why not test him now, before there was any chance for any morphing, just to see whether there was a drug out there that might be able to help him. And the doctor was recalcitrant. We had to ask him 3 times. And finally, I said to this guy, go in and you sit down with him and you tell him you want the test and your doctor wants the test. And the doctor in the end said, okay, I'll get you the test. And that was 6 weeks ago. 5 weeks ago. Well, last week, the results of one of the biopsies came back. And it was the lesser of the 2, meaning the one that was less likely to have mutations. And it did indicate one drug, everolimus, which is used occasionally. I've seen it used with a couple of guys. Dom, God rest his soul, took it. But what we really wanted was the other biopsy, and they didn't know where the other biopsy was. So my guy called them, and they said, oh, they didn't know. And he went in the next day, and they gave him the runaround. And I said, well, look, if you can't find anything out, because I have the connections, I'll call Foundation Medicine, and I'll see where that biopsy is. And Foundation Medicine were very helpful. And they chased it down. And what they found out was that the tissue for the biopsy, which had been sent out for a second opinion, was still sitting in the second opinion lab. And the doctor, when he ordered the test 5 weeks ago, had never bothered to chase down that tissue, even though he'd gotten the second opinion results a week before he ordered the test. A week before. And this is a man who's been told he's got 18 months to live. For me, it's criminal. This isn't an issue about who's right, who's wrong, who should have done it, who shouldn't have done it. It's criminal to take a month away from a man who's only got 18 months. It's criminal. So I asked Foundation Medicine to do whatever they could. The pathology lab locally did whatever they could. Meanwhile, these people in the medical doctor's office were still basically doing nothing. And my guy was not well. He'd had chemo, he was not feeling good. And I said to him, do you want me to call your doctor's office? He said, yeah, do you mind? Please call him. I said, I'm going to shake him up if I call him. No, please call him. So I did call them and I did shake them up. I shook them up to such an extent that the doctor got on the telephone, insisted on speaking with my guy who was sick in bed and got him out of bed, and said he was taking me off of his list and his office would never talk to me again. Now, I have a problem with that. This isn't an ego issue. It is, how do you get a doctor's attention? Why did this happen in the first place? For me, it borders on malpractice. How did it happen in the first place? And if you call and you ask nicely, they slough you off, which is what they did to my guy. And even after this happened, they still weren't doing anything. And my guy was calling me and was saying to me, well, please could you call this one? And please could you call that one? And please could you take good care? And I said no. And I said no for a couple of reasons. One, because it's not Foundation Medicine's job to go chase down tissue. They did it because I asked them to. And I will not abuse people that I have good relationships with. And they already went far and beyond. It's not the pathologist's office job to chase down the tissue. It's the job of the doctor that ordered the test. And this doctor had no right, he had no business ordering a test and not following through. And then when it was pointed out, still ignoring it. And then when he realized it was a serious error, going on the defensive or the offensive and blaming it on the advocate. And the patient, in this case, didn't stand up for me. And that hurt. Because what I do and what we do here largely is voluntary. If I was a lawyer and I'd called, the doctor wouldn't have had the balls to turn around and say, tell him not to call again. But because we're just advocates and we don't have the standing, but we know what's going on and we happen to know a lot more than most people and we can get to the bottom of a lot of issues, the doctors don't want to talk to us. They know they're wrong. This guy's got a problem. And it upset me a great deal. It upset me from the standpoint of community, yet again, community oncologists who aren't on top of what they're doing. It upset me from the point of view of him taking away a month from a guy that may not have a long time to live. And we may be able to find a solution for him. And it upset me from the standpoint of the relationship between myself and this particular patient, who again, even after this all happened, and even after he was on my case for what I did, still had the chutzpah to ask me, would I please call Foundation Medicine and have them chase up? I said, no, I won't. I said, you call your doctor's office every hour on the hour and get them to do it. Oh, I don't want to abuse my doctor's office. Well, you know, we have to make some tough decisions around here. I don't think this guy should be with this doctor. I wouldn't be. He chooses to be with him, that's fine. And then just earlier on today, I had a situation where a guy that's been on this call and has recurrent prostate cancer had reached out to our Medifit site and asked us for advice. He'd been on this call several months ago and asked for similar advice. He's a guy that chose to have sorry, I'm having a senior moment. He had his testicles removed rather than go on ADT on the advice of a doctor. which, you know, is always beyond me. Why they would give that advice. Now he regrets it. He needs to exercise. He called us. How could he exercise? And he wrote to us. We'd already told him. He wrote to us a second time. We wrote back to him. We gave him good advice. We gave him a trainer. And wouldn't you know, this guy turns around and writes to John Teisberg today that he never heard back from us. And again, I have a problem with that. You know, we're doing everything we can. This guy's never made a donation. He's never participated. He's never given anything back. He's quick enough to criticize. And what he does is harmful because it makes us look bad. And it's not true. And so all of this, you know, I sometimes have to step back and say, well, why do we do what we do? Because we know we make a difference, and we know we make a difference to a lot of you people. And we're not going away. But I think the bottom line is that if you want to work with an advocate and you feel they're making a difference, then you've got to support them. You really have to support them as well. And that support is not only morally, it's also financially. Some of us may need to take money out of what we do. Some of us may not need to. Those who don't, won't. And those who do, will. But we often bring more value to the path of your treatment than anyone else that you will deal with in the whole of your cancer experience. We cannot prescribe medicines, but we can tell you about medicines that other people are using and treatment paths that other people are doing, and we can ease your path, and that's what we want to do, and that's what rewards most of us. But we need a lot more than that. Hopefully, within the next 5 years, patient advocacy will become a recognized and respected profession. Right now, it isn't. And I've just given you a couple of examples of how that comes to bite you in the fanny. So I rarely do this, you know, most of you. I don't get on a soapbox on these calls, but this bothered me enough that since we had the time today, I just wanted to bring it to the attention of those who are here and those who will be listening to this call in the future. And if any of you want to say anything, you're more than welcome. But it's almost 5 o'clock.
Well, shame on that doctor, you know, who didn't realize the group he was dealing with and the power of advocacy groups and the power of social media and sites like Healthgrades where we can go on and comment about that doctor. Mm-hmm. And I think you're right, Rick, that advocacy is going to grow and grow. And every time any one of us, you know, sees a new doctor and says that we're referred by Rick Davis or Peter Kafka of ANCAN, and that starts getting around and around, it really has an impact on the way we're treated as patients and how we get the best care. So, you know, shame on that situation. And I would really, you know, go on to Healthgrades and give that doctor a bad review because people do pay attention to the 4 or 5 major internet sites where doctors are reviewed. And, you know, thank you for all you do, Rick. I mean, you're like, you are more valuable to me than, you know, any doctor individually I have. It's really the collection of recommendations I get from you and the people in the group here that really give me the confidence of which direction I should take. So
thank you.
Onward and upward, Rick, as you say.
Thank you. Thank you. Thank you. All right. Anybody else want to say anything? If not, we'll close out the call on that note. Okay.
Rick, again, thanks for what you do.
Thanks, Danny.
Yeah, thanks again.
Thank you, Rick.
Thank you, Rick. Okay, stay strong.
Thanks. I do have one positive thing to finish up with. Next Monday, I'm going to. I think I'm getting feedback from you, Peter. I'm just going to mute you for a second. Okay. Next Monday is a fifth Monday. It's a plenary, and we have a really, really exciting program for you. I'm just thrilled that we are finally going to get Donna Wilson onto a plenary call. And for those of you who don't know that name, he is the exercise guru at Memorial Sloan Kettering in the Bentheim Integrative Medicine Center. She's been doing this for a long time. She's a personal trainer. She's a pulmonary nurse. And it's just really, really exciting that she's agreed to present to us. A presentation is called, I think, still tentative, but I think it's called Keeping Moving. And she'll talk to you about her recommendations for exercise for men with prostate cancer. She runs a specific men's exercise group at Memorial Sloan Kettering, for which we do take some kudos, because with me supporting Richard Foodie, we convinced her that she should have a men's group rather than a mixed group, and she started that about 2 or 3 years ago, and it's gone from strength to strength. And Len Sierra participates in it, and Richard Foodie and a couple of the other guys who are occasionally on the call go into those groups. So very, very exciting. She's also the captain of the Dragon Boat team, and some of you may have heard Richard Foodie talking about Dragon Boat experiences. So that will be next week at 8 o'clock Eastern time for an hour and a half, plenty of time for questions. And there will be I believe there's going to be a deck, and we'll post that in advance. So don't forget, even though it's a fifth Monday, we are going to have some sort of a meeting next week. And Peter, as soon as I've got it all sorted, I'll send it to you so you can send it to your distribution. And Jake and John Teisberg, you can get it out to your distribution, etc., etc. All right, guys. Thank you for listening. Thank you for participating, and we'll talk to you all very soon.